Hello and welcome to the national testing discussion. Today is day 2 of surgery. I'm Dr. Shashank Baid, and today I shall be discussing the other questions. I shall continue from yesterday. So yesterday we looked at general surgery, we looked at trauma, we looked at plastic surgery, the other small specialties. Today our main focus will be on hepatopancreatic surgery, GI surgery and urology. So let's begin. In which of the following malignancies liver transplant is not contraindicated? So in this question they've given you 4 options of malignancies and they've asked you where liver transplant is not contraindicated. Now generally when you want to do a liver transplant for a patient, you must ensure that the patient does not have malignancy, because if any patient has malignancy, the treatment becomes palliative. However, there is one exception and the answer to that is colorectal cancer. In colorectal cancer, liver transplant is not contraindicated. In fact, even if there is liver mets in a patient colorectal cancer, you can actually do metastatectomy. That is, you can remove the part of the liver, or that is, you can remove the metastatic lesion. So let us look at liver transplantation in some amount of detail. So indications for adult liver transplantation fall into 2 broad categories. One is symptomatic liver failure, and the other is hepatocellular cancer. Now it is hepatocellular cancer. See, usually in malignancies, what do? We try to resect the tumor, right? But supposing if the tumor is so big that you're not able to resect the entire thing, right? Then you then you can do a liver transplant. So hepatocellular cancer, if the tumor location or accompanying liver disease prevents resection. That means if the functional hepatic reserve is very low. See, supposing say this is the liver, right? This is the liver. Now supposing say the tumor is this big, right? Then the patient can't live at only this much functioning liver, so that becomes a contraindication. Sorry, that becomes an indication for liver transplantation. Similarly, let us assume that the patient, he has gross cirrhosis of the liver, right? So, but the tumor is small. Now you can resect this, but the rest of the liver is anyways not functioning, right? So even though the tumor is so small, but the remaining liver is not functioning. So in such patients also, liver transplant is indicated. So let us look at a few tables and boxes. So disease states which cause liver failure that may be successfully treated with transplant. This is taken from Sabiston. So the first is non-cholestatic cirrhosis and second division is cholestatic cirrhosis. So the options in this are alcoholic liver disease, non-alcoholic fatty liver disease, hepatitis C, hepatitis B, cryptogenic cirrhosis. Cryptogenic cirrhosis means we do not know what is the cause of the cirrhosis, autoimmune cirrhosis and drug or exposure induced. Then cholestatic cirrhosis. Here you have cholestatic cirrhosis refers to all the conditions in which there is some amount of stasis of the bile. So primary biliary cirrhosis, primary sclerosing cholangitis, Caroli disease, choledochal cyst. So what are the common causes of acute liver failure? So this box that I've shown you over here, these are all chronic conditions. These are all chronic conditions. These will take years to develop and to progress, right? But there are some conditions, some causes of acute liver failure, right? That is, the liver failure happens very soon, in a matter of days to weeks. So for example, one is acetaminophen overdose. This is nothing but paracetamol poisoning. Then you have drug ingestion, indeterminate, where you do not know what the cause is. Hepatitis B. So please remember, hepatitis B and autoimmune diseases, they can cause both acute as well as chronic liver failure. Then you have hepatitis A, ischemia and Wilson's disease. Now what are the contraindications of liver transplantation? So see, any transplant, it is you're giving somebody's organ to a patient, right? And so now there are not unlimited number of organs. So you have to choose carefully as to which patient is going to receive the organ. Now, supposing say if you were to give a precious resource such as an organ to a patient who may not live long, maybe he has an underlying condition which will make him live only for 3 months or 4 months or 5 months, then there is no point wasting that organ on him, right? Unless that person is rich enough to buy an organ. Anyways, jokes apart, the patient should have some longevity of their own. They should have some minimum health standards, minimum fitness criteria before they can receive an organ. So contraindications are based on whether the patient can survive the operation, because the transplant operation is also itself a long procedure, right? And whether they can achieve a long-term survival. So the patient needs to be able to survive the operation, the patient needs to have longevity, as well as the patient should take care of himself. Now supposing say there is this patient who has drunk himself to glory. He's drinking, he's got cirrhosis. Now he needs a liver transplant. So supposing if you give him a new liver, he will continue drinking. So what is the point of wasting a precious resource on such a patient, right? So you need to ascertain whether the patient can properly care for the organ. That also is equally important. So what are the contraindications? So one, you have advanced cardiac disease, then severe valvular disease. See, these are all cardiac causes. Pulmonary hypertension, which may result in unrecoverable right heart failure on reperfusion of the new liver. So advanced cardiac disease, severe valvular disease, pulmonary hypertension, then coronary heart disease. Because patients who have coronary heart disease, they might get intraoperative myocardial infarction. See, patients who have underlying coronary heart disease, you can't even do. I had a patient where the patient wanted a lap cholecystectomy. The patient was around 79 years old, but the patient already had a CAPG done, and patient had features of underlying ischemic heart disease. So I told that patient, look, I can do the operation, you can survive. I can remove the gallbladder, but whether you will be able to survive the operation or not, that itself is in doubt. You might die on table. So once you tell that to the patient, many patients will lose interest. So likewise, supposing the patient has underlying coronary heart disease and you're going to do a long and morbid procedure such as liver transplant, they are at risk for intra-op myocardial infarction. Then patients with severe respiratory conditions. Then portopulmonary hypertension, which is uncorrectable to less than 50 millimeters mercury. So you can correct portopulmonary hypertension, but supposing if you cannot bring it to less than 50 mm mercury, that becomes a contraindication. Then hepatopulmonary syndrome, irreversible neurological impairment, because these patients can't take care of themselves, right? Okay. Now earlier it was thought that infection is it is an absolute contraindication. However, as time has progressed, as our field has advanced, we've realized that infection is not an absolute contraindication, right? So for example, supposing if a patient has primary sclerosing cholangitis and the patient has liver abscess, so liver abscess is an infection, right? But supposing if you excise the liver and you put in a new liver, that may be the only way for curing the patient. So that is not an absolute contraindication. But uncontrolled sepsis or any other infection that will not be cured by the transplant is a relative contraindication. So supposing you think that, okay, let me, if you do transplant the liver, but the patient has an uncontrolled sepsis and any other infection apart from liver abscess, but that may not be cured completely by the transplant, that is a relative contraindications. Then in most cases, extrahepatic cancer is a contraindication for transplant. Supposing the patient has a skin malignancy, the patient has a renal cancer or lung cancer. So in most of these cases, extrahepatic malignancies is a contraindication. But again, here there are subdivisions, there are exceptions. But as a general rule, extrahepatic cancer is a contraindication for transplant. Now, like I told you earlier, they thought that infections were an absolute contraindication, right? So supposing say earlier if a patient was considered HIV positive, patients who are HIV positive were considered to be contraindications for liver transplantation. However, new data says that even patients who are HIV positive, they also can undergo successful transplantation. Then active alcohol use. Like I told you, there is no point wasting a precious organ such as a liver on a patient who's anyways going to drink himself to glory. Now, once cancer goes to the liver, treatment is just palliative. So basically, this is what I told you. Coming back to the question, for almost all malignancies, once cancer goes to the liver, treatment becomes only palliative, with the exception of colorectal cancer. Okay, so this is a box taken from Bailey and Love. Let us look at a few salient features. So supposing if a patient has hepatocellular cancer, right, and you do a liver transplant, so you're simultaneously treating two things. You're treating the tumor as well as the underlying liver disease, because then you've not only removed the tumor, since the patient does not have enough functional hepatic reserve on his own, you're going to give a new liver which will take care of the hepatic reserve of the patient. So liver transplant for HCC simultaneously treats the tumor as well as the underlying liver disease. That is very important. Now you need to know what is Milan criteria. Milan criteria, basically it was criteria which was devised to allow selection of patients with hepatocellular cancer for liver transplant. That means if a patient has HCC and you want to determine whether to give whether to do a liver transplant for the patient or not, that is determined by Milan criteria, right? So Milan criteria says if you have one lesion of up to 5 centimeters or if you have 3 lesions up to 3 centimeters. Up to this, you can easily do it. That is called Milan criteria. So, one lesion up to 5 centimeters or 3 or fewer lesions up to 3 centimeters, right? Now, just like you have Milan criteria, now the thing is, as time has progressed, as data has advanced, as our field has advanced, we've realized that things which are earlier contraindications are no longer contraindications now. So, they've come up with something called extended criteria, right? Now, tomorrow, after a few years, when the next edition of Bailey comes out or when the next edition of Sabiston comes out, perhaps even these criteria will be relaxed, right? Now, there is one more criteria which you should know, that is the UCSF. This UCSF, it stands for University of California, University of California San Francisco. So, University of California San Francisco criteria, it is different from Milan criteria. It is slightly more liberal. So, you add 1.5 centimeters to the previous one. So, when you add 1.5 centimeters to this, you get one lesion of up to 6.5 centimeters and you get 3 or fewer lesions of up to 4.5 centimeters, right? But in this multiple lesion, there is a caveat. The total tumor diameter should not be more than 8 centimeters. So, it is one lesion up to 6.5 centimeters or 3 or fewer lesions of up to 4.5 centimeters each with a total tumor diameter of up to 8 centimeters. Now, there is one more criteria called UK-HCC criteria. UK-HCC criteria, it says one lesion less than 5 centimeter or 5 or fewer lesions all up to 3 centimeters or a single tumor more than 5 but less than 7. That is, let me write it down. In the UK-HCC criteria, you have, wait, let me write it here only. You have one lesion. Actually, this will be better for you because you can compare all three. So, here you have one lesion which is up to 5 centimeters or up to 5 lesions, all of which are up to 3 centimeters, right? Or one tumor which is, so see, it is one tumor with less than 5 centimeters. That is how they started with, but then they relaxed it to 5 to 7 centimeters. Why? Supposing say the patient has a tumor of 6 centimeters, right? Then it should not fit into the UK-HCC criteria. So they relax the norms. Supposing say if this patient's tumor size is not progressing over 6 months, over a 6 months period, right? Then that patient can still undergo liver transplant. Fine. Now, which is the most common tumor that requires liver transplant? So the most common tumors that require liver transplant in children are hepatoblastoma and HCC. So this is an MCQ question. Now, let us move ahead. Identify the focal lesion on CT abdomen. So, in the past couple of years, they are very fond of giving these image-based questions where they give you a CT scan image. Now, in many questions, there is no need for you to actually look at the image. You can solve the question even without looking at the image because some students, they have a phobia of images. Whenever they see image, they're like, I can't solve this question. I was one of those students when I was preparing for my NEET, I had a lot of difficulty looking at image-based questions. Unless the image was straightforward, I wasn't able to solve it. And images like CT scan, I used to just give it up actually. Like, no, I can't. This is not for me. But let me give you a few pointers. Now, the idea is that when you are looking at these images, you cannot become a radiologist, right? So, you should not look at extreme minute detail in order to solve these questions. But you should know a brief overview, you should know what to look at, what specific features to pick up so that you are able to solve the question, right? So, now in this patient, there is a CT scan. So, how do you know it is a CT scan? See this, you can see this bone, right? You can see the ribs. So when this is enhancing, that means it is a CT scan. Second thing, it is a cross section. So imagine you're looking at you're standing at the foot end of the patient, right? And you're looking at cross section. So imagine now I am standing here and the patient is lying down, like, wait, I am standing here, the patient is lying down over here. This is the foot end, this is the head end. Now the camera is going to come in between and look at sections in between, right? So now, so what is this lesion that is seen? So there are two lesions that this patient has. One is this lesion and this is the second lesion. So now in this lesion, the first lesion, if you look at it carefully, see, this is air and this is fluid. There is an air fluid level, that is the first thing that you can see. Second thing, if you look carefully, if you look at the margins, see, if you look at the margins carefully, you will notice that there are some white dots, right? This white is almost as bright as the ribs. So this is called rim enhancement. This is called rim enhancement. Now rim enhancement is characteristic of pyogenic liver abscess. It is characteristic of pyogenic liver abscess. So what is the second lesion? In the second lesion, you're not going to see, there is no ring enhancement, there is no air fluid level, and you can see it looks like a network, right? So there is one thing over here and you can see a lot of things over here. It looks like a network. This is a hemangioma. Okay. So this was, image of pyogenic liver abscess was given in the exam. So this will be your answer, liver abscess. Now let us look at this in slightly more detail. So when you do a CT scan, let us look at pyogenic liver abscess in more detail. So when you do a CT scan, you normally will see a multiloculated cystic mass. You will see air fluid level. You will see rim enhancement. And CT scan, it can even detect small abscesses. So these features we already looked at in the image. Next, what is the route of spread? That is, what is the etiology of a liver abscess? Now, the most common source is biliary tract pathology. So earlier in the in pre-surgical days, if you go at like, not pre-surgical, if you go 100 years ago, the most common cause used to be appendicitis. See, the liver is receiving a lot of blood. The liver has two sources of blood supply, right? One is the hepatic artery from the heart. Second is the portal vein. Portal vein is accounts for around 2/3 of the liver supply. Portal vein is around 2/3 of the total blood supply. Hepatic artery is 1/3, right? So if there is any source of infection in the bowel, in the GIT, it is all going to be carried into the liver, correct? So in the olden days, when they would look at it post-mortem, they realized that appendicitis was the most common cause of hepatic abscess. But we've lived in an era where many patients have undergone, nowadays patients do not really die from acute appendicitis. Nowadays patients, they undergo surgery, right? Actually, if you look at the list of, so I don't know how many of you are cricket fans. So there are, if you look at the list of the top 10 cricketers of all time, I've forgotten this cricketer's name, but he was an English cricketer and he played very well in the Ashes. He played, I think, around 130 years ago, and close to the end of 19th century up to the starting of the 20th century. From around 1890s to 1910 he played. He was a brilliant player, and he had a sister who died of acute appendicitis. It was devastating for him and he stopped playing cricket. I can't recall his name right now. Anyways, the point I'm trying to make is, in the earlier days, a patient would die of acute appendicitis. So not only because of the complication of acute appendicitis, but also the infection could spread from the appendix to the liver and cause a liver abscess. However, as appendicitis is being treated nowadays, you rarely find someone dying with acute appendicitis, right? In today's day and age, if somebody dies of acute appendicitis, it is a matter of shame, not just for the doctors, but also for the community as a whole. So anyways, in today's world, the most common cause of liver abscess is biliary tract pathology. Second most common is portal spread from GIT, such as, for example, if the patient has diverticulitis, appendicitis. Then contiguous spread from subphrenic or intra-abdominal collections. Right. Now, I had assisted my senior in a case where this patient had empyema gallbladder. He was refused by almost 4 or 5 surgeons. So when he came to sir, he was in a very critical condition, and the CT scan showed not just empyema gallbladder with perforated gallbladder, but there was also a huge liver abscess. So we were thinking what approach we should take, what incision we should make. So anyways, we ended up giving a subcostal incision. So as soon as we made the incision, pus started flowing out like a fountain, right? So what had happened in that patient was, the patient had empyema of the gallbladder. Now the gallbladder, it is adjacent to segment 4B of the liver, correct? So when the gallbladder is attached, supposing say this is the gallbladder and this is the liver, right? So supposing there is empyema over here. Now for some reason, supposing if the posterior wall of the gallbladder erodes, so now the pus is in contact with the cystic plate. Now the pus in some patients, depending on the immunity of the patient, the pus can, and the causative organism, depending on the causative organism, the pus can actually, the infection can actually, eat away on the cystic plate as well as in the liver. So in this patient, what had happened was, there was empyema, there was collection of pus, and that pus eroded the cystic plate and into the liver. And there was almost, I think we evacuated close to 1200 ml of pus. So contiguous spread is also a cause for liver abscess. Then bacteremia secondary to trauma or infected cysts. Common sense question, common sense option I mean. And necrotic tumors following chemotherapy. This is a potential question in the exam. Necrotic tumors following chemotherapy. You have also a sixth root called cryptogenic. Cryptogenic, as the name itself suggests, it means that you are not sure as to what has caused the liver abscess. Now, what are the causative organisms? Causative organism, it is usually a polymicrobial condition, right? Most common organisms are Klebsiella, E. coli, and Streptococcus milleri. It is not Streptococcus pyogenes, it is Streptococcus milleri. Now, supposing if a patient has a liver abscess, how do you treat such a patient? So, first you will give antibiotics, obviously. So, you will give the patient penicillin plus aminoglycoside plus metronidazole. Or if the patient is allergic to penicillin, you might give a cephalosporin and metronidazole. So, see, metronidazole is given in almost all, in many GI conditions. So, even when you are doing a laparotomy and you are not sure as to what might be the cause, you usually can safely give prophylactic metronidazole, right? Okay. Now, we are living in an era of minimal invasive surgery. If something can be done, so basically if something can, supposing say if there is a closed door, right? If you can look into the room via keyhole or, by just drilling a hole, that is better than breaking open the door and then looking inside what is happening, right? So, we are living in an era of minimal invasive surgery, and so tomorrow when you become a general surgeon, you will become irritated because many cases which were earlier done by general surgeons are now being done by radiologists, by interventional radiologists. That is also a very upcoming field. So, CT guided percutaneous drainage. So now there is no need to make a huge incision, right? You just localize where the abscess via CT scan, and then you insert a pigtail catheter. What is a pigtail? So now supposing say this is the liver, right? Now this is the abscess. Supposing if you insert a drain just like this drain is not going to stay in place, it is going to come out, right? So what you do is you insert a pigtail catheter. So what is a pigtail catheter? As the name itself suggests, it is something like this. It goes and it is coiled like a pig's tail. So when it is coiled, that coil helps it to stay within the cavity of the lesion, right? So pigtail catheterization is better than simple aspiration. So many patients, they don't really want a drain, or many surgeons are not really fond of the drain. They're like, okay, let me aspirate the pus and leave it. No. Studies have shown that if you just aspirate the pus, that is not really enough, because there might be new formation of pus, right? So what are the indications for open surgical drainage? Even though radiologists are trying to take away the cases of general surgeons, so a surgeon is, me being a surgeon, I'll tell you, the surgeons are the most supreme doctors, and there are conditions where, the radiologist fails and then ultimately they have to come to the surgeon. So, but upfront, supposing if a patient comes to me, what are the indications for open surgical drainage? So, failure of percutaneous drainage. So, patient has gone to the radiologist and the radiologist has not been able to drain it for whatever reason. It may have been a multiloculated abscess, right? Or maybe it was situated in such a place that it was inaccessible in a percutaneous route. Then patients who require surgical treatment of the primary pathologic process. So the patient not only has the liver abscess, but he also has a primary pathological process which is causing the liver abscess, right? Okay, next. Now, obviously, so like I come from Kolkata, and there are, even if when you go to the peripheries, there are so many patients who can't really afford coming to a city, and there are many places where it is not really available, where a interventional radiology is not available. So in that scenario also, you can do open surgical drainage. Okay, so next, let us look at amoebic liver abscess. Now, I won't discuss it in as much detail. Let me just look at the salient features. So, which part of the amoebic liver abscess, there will be two places of pathology. One is in the liver, second is in the colon, that is in the bowel, large intestine. So, which part of the large intestine is most commonly affected by an amoebic liver abscess? So, the answer is the entamoeba histolytica, which is causative for amoebic liver abscess. Entamoeba histolytica. Entamoeba histolytica, it has a predilection for the cecum and ascending colon, right? Then you will see flask-shaped ulcers. So, see, when you take a biopsy of the lesion, now you see this is the shape of the ulcer, right? This looks like a flask. This is like the shape of this, right? That's why I placed a flask adjacent to it. So, you will get flask-shaped ulcer. This is pathognomonic. This is pathognomonic of an amoebic liver abscess. Then you will see discrete exudate covered areas of ulceration with normal areas in between. So, it need not be a continuous lesion. You might see areas of normal bowel in between, and biopsy can also be taken. That is fine. So, see here also they are showing you the same thing. This is the ulcer. This is the epithelium. This is the epithelium. This is the bowel lumen, right? And there is a break in continuity in the epithelium. This is the ulcer, right? This is a flask-shaped ulcer. So, for a patient with an amoebic liver abscess, if you do a USG, what do you see? So, you will usually see a round or an oval shaped cystic lesion. Now, these lesions are usually solitary, but they can be multiple. Second thing is, it is usually hypoechogenic or anechoic interior. So, in ultrasound is about sound waves, right? So, when you give a sound wave, depending on what the way it returns back to the probe, that determines the echogenicity. So, amoebic liver abscess is usually hypoechogenic or anechoic, that is, there is no echo or less of an echo. That is because of the fluid content. Now, supposing say if this lesion were to be solid, right? Let us say it is a hepatocellular carcinoma. In that patient, you will get a hyperechogenic, you will get a hyperechogenic reflection. Then, well-defined margins. The margin is not only well defined, but it is solid, right, compared to the interior. That is why the wall is echogenic. Then posterior acoustic enhancement. You will get this posterior acoustic enhancement or a posterior acoustic shadow due to the fluid content. Now, posterior acoustic shadow, that is wall acoustic shadow, if you have to answer one condition which causes a wall acoustic shadow, your answer should be a gallstone, right? Then there is no significant wall calcification. So, calcification very rarely occurs in amoebic liver abscess. See, so whenever, I don't know how many of you have drained an abscess in your internship. So, when you make an incision in the abscess and you drain out all the pus, now how do you know that you've finished removing all the pus? So, initially when you make the incision, you put your finger and you're probing in, pus comes out. After some time, you will notice that blood is coming out, right? The pus is mixed with blood. That is because all abscesses, they are surrounded by a vascular rim. That vascular rim is causing the rim echogenicity that we saw earlier, that we discussed in pyogenic liver abscess, right? But now that uh, pyogenic rim, that is the that one pyogenic membrane, the vascular membrane, the blood vessel membrane. So supposing say this is the pus, this is the abscess. Let me use a different color. See, this is the abscess, right? So when you put an incision, pus comes out, but later on blood will start coming out because that entire pus, it is surrounded by a vascular rim. So in what is that? In amoebic liver abscess, you will not see this vascular rim. So if you look over here, you can't really see that vascular rim. See, there is no rim enhancement. So here you can see it is of rounded shape, and here it is multiple, but it is usually solitary. Then it is the other features we have already discussed. So what do you see on a CT scan? So just like it was hypoechogenic on ultrasound, on CT scan the abscess will appear to be hypodense. There is no enhancement or peripheral enhancement, there is no calcification, right? So what do you mean? See, peripheral enhancement is only the rim, but no enhancement. Enhancement is, let me show you an earlier image. This was our first image, right? See, if you look at the hemangioma, hemangioma is a hepatic benign tumor of the liver, right? So here, when you do a triple phase CT scan, in an arterial phase, that is when there's something called a triple phase CT scan where you have three phases, as the name suggests. In the arterial phase, the dye is taken up by the tumor, right? So there is enhancement of that. Now, since it is a hemangioma, it is like a network of blood vessels. So the dye is retained in the hemangioma for some time, and there is, see, ultimately the dye has to wash out, right? But there is delayed washout, which is typically seen in hemangioma. See, so this lesion is bright, but it looks like a network. That is why it is a hemangioma. So where were we? So there is no enhancement or no peripheral enhancement, and there is no calcification. So see, when you look at this patient, see in this here the lesion is round, right? This lesion is round. Now you will tell me that, sir, I can see three shades. So see, radiology is all about shades of gray, 50 shades of gray. So see, here you have one shade, here you have another shade, this is dark, and here you can see a third shade, right? Here, if you're careful enough, you can see a third shade. So is that rim? It looks like a rim. So then you'll ask me, is that rim? I'm like, no, this is not rim. Rim enhancement is when the rim resembles the shine of the bone. That is called rim enhancement. Here you are seeing rim because wherever the lesion is located, there is some amount of edema around it, right? That edema is responsible for this rim, but there is no rim enhancement. So CT scan of amoebic abscess, the lesion is peripherally located and it is round. Rim is non-enhancing like I mentioned, but it shows peripheral edema. See, here also you can see good amount of edema. See, you can see there is one shade over here, one shade, third shade, this is the second shade, right? You can see a different shade over here. This is the rim. This is because of edema. And see, if you notice over here in this arrow, see, these are the ribs. So this is the intercostal space. Now, in this intercostal space, see if you were to put a drain like this, it would drain the entire thing out. Okay, so what is the treatment of amoebic liver abscess? So amoebic liver abscess is a treatment where medical treatment is very effective. There is you don't need to really resort to surgery. So medical treatment, suppose when the patient comes to an elective scenario, right? Now if the patient is septic or if the patient has undergone secondary infection of the amoebic liver abscess, then it is a different thing. But supposing patient has come to you in an elective state, the best thing would be to do a medical treatment. So what drugs will you give? You will give metronidazole and tinidazole, which will look after the pathology in the liver. You also have to take care of the pathology in the bowel, right? Because there is some amount of there might be those flash shaped ulcers in the bowel, right? cecum, as we saw earlier, cecum and ascending colon are the sites where it is most common. So if you give metronidazole and tinidazole, they will not act against the amoeba in the cecum and ascending colon. So you have to give something called a luminal amebicide. You have to give a luminal amebicide, right? Example of that is diloxanide furoate. So this is used for 10 days to destroy any intestinal amoeba. So you have to give 2 drugs. Along with metronidazole, you will also have to give diloxanide furoate. Then there is percutaneous aspiration and drainage. Again, the radiologists have taken this case away from surgeons. So it is done under USG guidance or CT guidance. Now you tell me, sir, you just told that medical treatment is the treatment of choice. But supposing if the abscess you expect it to rupture. See, if you look at the previous image, here you can see a bulge, right? See here you can see it bulging. See, this is coming. It is bulging here. So there is a high chance that this is going to rupture. Here there's a high chance it is going to rupture, right? So when rupture is imminent or when you feel that it might rupture, it is better to put a drain. See here also, supposing if it ruptures over here and it enters into the subhepatic pouch or into the subphrenic space, then it may not be, you might have to do a surgery, right? So it is better to aspirate this pus by leaving a drain or a catheter inside it, right? So aspiration is carried out when imminent rupture of an abscess is expected, especially when involving the left lobe, right? Then pigtail catheter may be considered in those patients who are not responding to IV metronidazole in the first 40 to 72 hours to improve antibiotic penetration. So supposing, say, now metronidazole is one drug against which there is no resistance. Till date, it has 0 resistance, right? Now supposing, say, but if you're giving metronidazole for 2 days, 3 days and you see no response, then you might consider pigtail catheter. Now, why did we separate out this left lobe? Why is left lobe more special than right lobe? Because the left lobe, it can rupture into peritoneal pleural or even in the pericardial cavity. Right can rupture into the peritoneal, right? But left has a higher chance of rupturing into the pleural or into the pericardial cavity. So if it is on the left side, it is better to drain it. Then open surgery, that is a laparotomy, is indicated only for complications. There is no need to do it routinely. Supposing if it has ruptured, or supposing it has undergone secondary infection, it has become multiloculated. You are not able to drain it with a pigtail catheter. What is the meaning of multiloculated? Now, supposing if this is the abscess, you put you aspirate or you put a drain, you are able to drain the entire thing. But supposing you get loculations inside it, supposing you get loculations inside it, so it has formed something like this. So when you put so there are walls in between. So when you put your catheter, it might drain this, it might drain this, it might drain this, it might drain this, but it won't drain all this because these walls are coming in between. So during your internship, if you've drained an abscess, you would have noticed that when you put your finger in, your senior would have told you to put your finger and to break all the locules. Only when you break all the locules, the pus come out. This is what those locules are. Supposing if you do a surgery, then what surgery do you do? So you will be doing a drainage plus a lavage. Okay. So moving ahead. So now that we've discussed, pyogenic liver abscess and amoebic liver abscess, let us discuss a hydrated cyst. Now a hydrated cyst, what features do you get on ultrasound? It is well defined, it is anechoic or it is hypoechoic cyst with a thick wall, right? The cyst, it may contain debris or hydrated sand. So you have all those daughter cysts, right? They might get detached and they might settle in the bottom. That gives rise to what is called the hydrated sand. Now in hydrated cyst, see, doctors have very boring lives, right? So this doctor, perhaps you're very frustrated like you guys are sitting at home, you're not able to go out, you're not able to enjoy life unlike your engineering classmates. So these radiologists, this doctor, whoever he was, he wanted to go and look at water lilies. Maybe his wife was eating and said, show me water lilies. But he did not have time because the profession is so demanding. So he instead started seeing water lilies in the radiological images. So some psychos, supposing if you or I were to look at this image, we would just describe the image. But some psychotic doctors, they have to look at fruits and vegetables and animals and astronauts and so much more, right? So see, supposing say there are three friends walking on the road, and one of them looks at a cloud and says, look, that cloud is shaped like a lion. The other two will think, hey, what kind of a psycho you are, man? That is just a cloud. Why are you giving it so much importance? Similarly, with these doctors also, they were not normal doctors actually, so they had to look at something in it. That is why. Anyways, jokes apart. So, water lily sign or a lotus flower appearance is very, very pathognomonic of hydrated liver abscess. So, what is this water lily sign and why do you get this? It is because of a detached endocyst floating in the cyst. So, you might have the hydrated cyst, within it you have the daughter cysts. So, supposing say this is the hydrated cyst and this is the daughter cyst. Supposing say the daughter cyst becomes detached. So, this was the cyst, this is the daughter cyst, it becomes detached. Over time, this is the cyst and the daughter cyst may take this shape. That is why it is called water lily sign, right? And so, supposing say if there are, this is the cyst and you get lot of daughter cysts, then this looks like a honeycomb. So, you might get honeycomb appearance as well. So, see if you look at this image over, let me erase all this. So, if you look at the first image over, if you look at this A image, you can see something float, you can see a demarcation over here, right? Then you can also see these dots. This is nothing but hydrated sand. Nothing but hydrated sand. Now, what do you see in this B image? So, you see a main cyst, right? And then you see a main cyst. This may be the hydrated sand. And you are seeing over here, see there is one septation over here, one septation over here, one septation over here. This is called a rosette appearance. See, here it is more clearly seen. This is called a rosette appearance. This is daughter and granddaughter cyst and typical rosette appearance. Now, what do you see in this image? See, in this image, you're going to see this is the cyst, right? And instead of the sand that you see over here, see this dot 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 thing was the sand. Here it forms an amorphous mass, right? And this it might look as though it has become solid or a semi-solid appearance, right? And one moment. Now, the thing with hydrated cyst is hydrated cyst might calcify. The rim might calcify. So, if you look at this D image, you can see this calcified, right? You can see this also calcifying. This looks like an eggshell calcification. So, now whenever a hydrated cyst ruptures, right? Whenever a hydrated cyst ruptures, if the contents leak out into the peritoneal cavity, it can cause anaphylaxis. So now I don't know how many of you have seen the show called House MD. So there was this guy who comes to visit house. He's been turned away by many doctors, and the other doctors are not able to tell what is wrong with him. So as a last resort, he's come to house, and house has heard of him. House has heard that he's a problematic patient who doesn't really have any problem, but he keeps coming again and again to doctors. So house tries to get rid of him. So what house does is, house sees a cripple, right? So he carries a stick. So when he hits that patient with a stick on somewhere in his rib cage, near his rib cage or in his abdomen, the patient goes into anaphylactic shock. So that prompts house to admit the patient under him, right? Because if you hit somebody with a stick, that doesn't make you go into an anaphylactic shock. So house did not realize at that moment that it was an anaphylactic, that it was due to hydrated cyst, but that is what piqued his curiosity. Now, the reason I'm telling you this is, one more thing that I want to tell you was, so supposing now you guys are preparing for NEET PG, right? Now, if you guys want to give some leisure time, if you want to have some leisure time on an everyday basis, I would recommend that you watch a show called House MD. House MD was popular when I was in my MBBS days, and many of us used to watch it. House MD is a good show for you to watch. Do not look at the relationship between all the doctors. That is of no consequence. You can look at your own classmates for that. The reason why you should watch House MD is because there are so many interventions, so many drugs, so many protocols, for example, which when you look at House MD, you will recall it in your exam. So for example, when I was preparing for my NEET PG, I remember that I had very difficulty in memorizing the stains. So amyloidosis, it requires Congo red stain. So I remember even today, I remember there was an episode of House where there is a minor girl who has a crush on House, and one day she wears one day she's showing her undergarments to House, she's showing her panties to House, and that is of Congo red color. So the moment House sees that color is, I mean, he registers that color to be Congo red, and he solves the case. Now, if I tell you to remember amyloidosis Congo red, you might find it difficulty. But supposing if you were to get a visual clue such as this, you will remember it. So, if you want to watch one show for leisure or for entertainment, you watch House MD. It is a very good show, and there are so many things which you can see in the show, which you can learn from the show. Anyway, so like I told you, this is rosette appearance. So I have just added a image of a rosette. This is what a rosette actually I'm very fond of. When I see these ultrasound images and I see the rosette or honeycomb appearance, I always put an image of, like, see earlier you saw I put an image of a flask, right? So I always put the image that it is being compared to side by side so that you can actually get an image. So this is also a rosette. This is what is fried, and this is the rosette that you attach on your shirt or whatever. So this is the water lily sign that I earlier described. So when you look at a lotus or a water lily from on top, see in this second image, when you look at it from top, this is what it looks like, right? Similarly, this also, this is what it looks like. Then this is the honeycomb sign. Honeycomb sign will also have a cartwheel appearance. This is another name to it. So doctors have very boring lives. One doctor saw a honeycomb, one doctor saw a cartwheel. So what are the other features? What are the CT scan features of hydrated cyst? So here what I want you to really appreciate from this image is the eggshell calcification. This is the eggshell calcification. So see, how do you know it is eggshell? It is the same as the ribs. The shine in the white color is as good as the ribs, right? Okay, so what is the treatment of a hydrated cyst of the liver? Now, a hydrated cyst is ideally managed in a tertiary unit by a multidisciplinary team of a surgeon, physician, interventional radiologist. Anyways, asymptomatic and inactive cysts are left alone. So if the cyst is asymptomatic and if it is inactive, for example, if it has become calcified, you leave it alone because it is not going to cause any problems. But supposing if it were to increase in size, then it is problematic, right? Because if it is increasing in size, it will eat away, it will gradually compress the liver, right? So you have to monitor the size by USG. Now supposing say the cyst is active, then you first treat the cyst with a full course of albendazole, because albendazole will then kill the organism in the hydrated cyst, right? What organism causes hydrated cyst? It is Echinococcus granulosus. That is the most common cause, Echinococcus granulosus. That is the most common organism. So you first give a full course of albendazole. You can also use a drug called praziquantel, right? And you ensure that these organisms die, and then you operate. So what operation will you do? So there is a very, I like this procedure a lot. It is called PAIR, and why I like it is because they've made a very they made a simple thing very, very complicated. So I mean, now many people, they are very fond of these acronyms where these abbreviations basically. So anyways, these are one such group of people. So where PAIR stands for puncture, aspirate, inject, reaspirate. So whenever you're treating a hydrated cyst, you have to be absolutely certain that there is no spillage of contents into the peritoneal cavity. So what you do is, supposing say this is the cyst, you puncture it, right? And you do not drain it, you aspirate it, because via the puncture only you have to do not make it bigger. Puncture, aspirate it. So once you aspirate it, then there might be some, there will obviously be some more the organism inside, right? So you want to kill that. So you inject a scolicidal agent that will kill it, and then you re-aspirate it. You do it repeatedly. Now this PAIR is it is a minimal invasive procedure. Anyways, so after puncture and aspiration of the cyst, a scolicidal agent is injected into the cyst. So this is also an MCQ question in the exam. Name some scolicidal agent. So the answer is hypertonic saline, which is 15 to 20% saline. Normal saline is 0.9%. So if it is 15 to 20% saline, it becomes hypertonic saline. Then ethanol, which is 75 to 95%. So you can use the surgical spirit, which is easily available in the hospital, or povidone iodine. So after injection, contents are re-aspirated, right? Now before pair is done, you must ensure that the hydrated cyst does not communicate with the biliary tree. Why? Because when you're going to inject this scolicidal agent, that might enter into the biliary tree and cause cirrhosis. It might cause biliary cirrhosis, right? So to prevent that, you must ensure that the hydrated cyst is not communicating with the biliary tree. If scolicidal agent is accidentally injected into the biliary, it can cause sclerosing cholangitis, which can then lead to cirrhosis. Now, pair can be done open surgery or laparoscopically, but it's more commonly done laparoscopically. Then what is the other ways of treating it? So you can also do something called a pericystectomy with an omentoplasty. So this is done especially if the lesion is in a peripheral part of the liver. So supposing if the lesion is in an part of the liver where it is not accessible, that means there is normal liver tissue. To explain. So this is the liver and this is the hydrated cyst. Now here can you do pericystectomy? Obviously you cannot do, because you have to remove all this liver tissue, right? So supposing, say, if this cyst were to be present in such a place, it is accessible to you, then you remove this, you do a pericystectomy and you plug that defect with omentum. That is called omentoplasty. Then is hepatic segmentectomy. Hepatic segmentectomy, supposing if the lesion is in a peripheral part of the liver, you can actually excise the segment itself. Last, you have something called laparoscopic marsupialization or de-roofing of the cyst, where you remove the cyst containing the endocyst along with the daughter cysts, right? So let us continue. A 35-year-old male presented to the OPD with right flank pain. So flank pain, CT image is shown below. Which of the following statements are incorrect? So if you look at the CT image, you are seeing this, you are looking at this rosette appearance, right? So that means it is a hydrated cyst, and this is the kidney. This is not the liver. So how do you know it is the kidney? You can see this is the kidney on the right hand side. This is the pelvic calyceal system of the kidney, and this is the left kidney. This patient has a hydrated cyst of the left kidney. So which of the following statements are incorrect? Will you give albendazole? True. Caused by dog tapeworm? True. Yes, you will. Dog tapeworm is nothing but Echinococcus granulosa, which I discussed earlier. Leakage of the cyst can cause anaphylaxis also? True. FNAC is required before surgery? No. See, FNAC is usually done when you want some diagnostic clue. It is an investigative modality, right? It is not therapeutic modality. But hydrated cyst is beautifully diagnosed on the imaging investigation itself. There is no role for FNAC. So this is the answer. It is the incorrect option. This is another image where they are showing you, this is the kidney, right? This is the liver. This is where the liver is ending. This is the kidney, and you can see this honeycomb appearance over here, right? Okay. So moving ahead, a 25-year-old patient presents with fever and slight weight loss. Fever and slight weight loss. He gives a history of blood in stools. Blood in stools means there is colitis, right? Now, let us see the remaining. On examination, there is a right hypochondrial pain and hepatomegaly. So there is a pathology in the colon, there is a pathology in the liver. Automatically, you will think of entamoeba histolytica. That is nothing but amoebic liver abscess. Imaging is shown below. What is the diagnosis? So like I told you earlier, not all questions where they give you an image can be answered only by looking at the image. So this is an example of a question where if you are image phobic, you can still answer the question and get it correct. So this image we already discussed earlier. This is the image where it is bulging into the intercostal space. This is nothing but amoebic liver abscess. Now let us look at the differences between an amoebic liver abscess and a pyogenic liver abscess. So amoebic liver abscess is usually present it affects younger age group, that is 20 to 40 years age group, right? Whereas pyogenic abscess will affect patients who are more than 50 years. Then amoebic abscess is way more common in males. See, both amoebic as well as pyogenic abscess are more common in males, but amoebic is more common in males than females. This is by the ratio. It is 10:1. Here it is 1.5:1. Then amoebic abscess, it has a higher chance of being solitary. So the way I used to remember this is because A for amoebic, A for akela. So this is akela. Now there are so many exceptions in medicine. There are no, what is that? It's medicine is not rigid. You can always have exceptions. So usually A for amoebic, A for akela, it is usually solitary. That is 80% of the cases it is solitary. Whereas a lesser portion of pyogenic abscess cases are solitary. Both amoebic as well as pyogenic liver abscesses are more common on the right hand side. This is because of the laminar blood flow. When the blood flow is when the hepatic artery branches into the right and left, because of the laminar blood flow, it preferentially goes into the right liver, all the pathology. Then history of travel in endemic area, yes. So patients who have amoebic liver abscess, since it is caused by entamoebic histolytica. Entamoebic histolytica is also responsible for what is that called? Traveler's diarrhea, right? So there is a history of travel in endemic area in amoebic abscess patients, but that history is not present in pyogenic abscess. Now, diabetes is more common in pyogenic abscess. So see, it is more common in elderly age group, more common in slightly immunocompromised, and diabetes will cause that compromise. Now, alcohol use, usually alcohol is associated with almost all liver diseases, right? So alcohol use is common in both. Jaundice is uncommon in amoebic abscess, but it is common in pyogenic abscess. So similarly, elevated bilirubin is same thing actually, jaundice, and elevated alkaline phosphatase is common to both. This is a very important table. This is taken from Saviston, and a lot of questions come from this table. Positive blood culture, no. In amoebic abscess, the pathology is in the liver and in the colon, right, in the ascending colon and the cecum. So you will not get a positive blood culture there. But in pyogenic abscess, you will get a positive blood culture, because here in the what is that? The infection is traveling via the portal vein, right, in pyogenic abscess. Positive amoebic serology, yes, obviously here it is no. Okay. So moving ahead. So anyway, I think we'll take a break over here, and so 1 hour this discussion was on YouTube. For remaining discussion, you will have to come to the app.